So Paula asked me to just talk about two aspects of spina bifida, so we'll talk about the Chiari and the Hydrocephalus. So spina bifida is an important disease. I don't have to tell this audience, but more and more people are starting to take an interest from this group, the Spina Bifida Association, even more importantly because they have bigger coffers, the CDC, the Center for Disease Control, the Hydrocephalus Association, because spina bifida is a large part of hydrocephalus, and vice versa, and then the Hydrocephalus Clinical Research Network, which I'll talk about. So first of all, we'll just talk about Chiari II, and so I hope things are projecting well. Let me turn down I don't know how to turn down the front lights just a little bit. But on the left here, we have the brains of a baby with, or anybody with spina bifida or Myelomeningocele specifically, are quite different than those without. So that's a patient on the right with a Chiari I, so that's just quite a bit different than a Chiari II. And so important things, pointer's going to show up. So we can see, like instantly my residents should be able to look at this and say this child has spina bifida. The tectum is beaked, the aqueduct is gone, there's this large mass intermediate here, a thin corpus callosum. None of those have very many meaningful things other than recognition, but the posterior fossa, which you'll hear me talk about, this area, is small. And another important thing, which is probably more problematic, is that there's migrational abnormalities. That means neurons, when you're a fetus, follow a certain pattern and head on out and to where their final resting place will be. And sometimes they stop short or they don't make the trip. And that is probably the leading cause of, number one, seizures, and number two, cognitive disability. Okay, but specifically, so Chiari II. So it's just one of that group. So what is the Chiari II? So here is zoomed in on the posterior fossa. You'll hear us talk about that. And it's primary children's band that I'm tunneling in here. Okay. So basically, what's different in Chiari I, just the cerebellar tonsils squeeze down, but in Chiari II, the whole brainstem, where all your automatic functions, breathing, eye movements, are carried, and it's come down into the spinal canal as well. And sometimes the fourth ventricle has come down as well. Okay, so it's quite a bit different, and we're not quite sure. We think maybe the open cord and the leaking at the bottom is causing this posterior fossa to not grow enough, and so it's small, and so you're ramming the same amount of stuff into a smaller box, and that's why it's coming down. Another thing to note is the torcula. So all the major draining of the brain's veins come together in one spot, right back here. Okay, probably the most important venous spot in the body, or maybe the right atrium of the heart. But and then comes down your jugulars and then goes to your heart. And so that's a very important structure, which we'll talk about. So why do we talk about Chiari II? So how does it present? So I'm going to give you the classical presentation and then the real one. So brainstem compression. So babies are most common to present with it. Stridor. So stridor is when you can hear the baby breathing in and out. It sounds like they're struggling. It's like not, believe it or not, there's definitions for this. It's not a wheeze, but it sounds like what is commonly thought as a wheeze. Aspiration is when food goes down the wrong pipe and goes into the lungs and can cause pneumonia. Choking, swallowing problems. Apnea is when not breathing very well, not oxygenating very well. And vocal cord paresis. Most babies with spina bifida and Chiari II have some degree of vocal cord paresis. Older children, classically it's taught, they can get weaker from a Chiari II or have more spasticity, but we'll talk about that in a second. So brainstem concussion. When all these babies are born, there's always a lot of discussion about whether it's the Chiari II acting up. So behind the scenes, maybe the parents aren't seeing this, but the docs are all talking about this. Mostly, other people are talking like it's a Chiari II, that's why they're not breathing well. But these babies have other issues, and so it's our job to sort out when it's real or not. So the important key is if you see us and we're like, well, I don't think it's the Chiari II. The reason is on MRI, most babies have a Chiari II with spina bifida, and it always looks compressed. So just because things look squished on an MRI doesn't mean they are squished. So if you're born squished, your brain's never known anything else, and so it can tolerate that. The brain just doesn't like changes. Okay. So the symptoms that we sometimes attribute that I showed you are very frequently actually symptoms of hydrocephalus, or just an immature brainstem. So there's a lot of work going on. A lot of here, Dr. Schoenwolf at the University of Utah does a lot of this work about genetic mutations and why this happens. And sometimes that exact moment when the spinal cord is supposed to roll up, that Dr. Kerr just briefly showed, there's other very important things going on. And so if there's a problem at that moment, there could be other problems, and then the wiring of the brain is not as it should have been. That's the migration that we're talking about. The reason why I make a living doing surgery, but we are usually the pushers back because this is a dangerous operation. This is by far the most dangerous operation a spina bifida child can do. Well, maybe scoliosis, but that's a big surgery, but not specifically dangerous. This one, the structure's one wrong move and it can really hurt a baby, and it's mostly historical. So that's why I say beware the diagnosis of brainstem compression, and because we take stridor and aspiration very seriously. Choking and swallowing problems, it's a little harder. To be a little less specific, but apnea, and I told you most kids have vocal cord paresis, so we don't really pay too much attention to that, and there's a million reasons for a baby to have apnea. And really, we don't think the Chiari II has a big role in older children walking. If there's problems walking or ambulation, it's almost certainly tethered cord or some other orthopedic issues. And what we're taught, we're drilled, you're going to meet Dr. Walker, and this is the most common thing he says, it's always the shunt. Okay, so it's not always the shunt, but if you're worried about Chiari II, you better check the shunt first. So we will do a shunt operation, even though we don't think it's the shunt, before we do the Chiari II operation. So what about other things? There used to be a school of thought that the Chiari II caused hydrocephalus. We don't really think that anymore. We think it's just a part of the same syndromes, but we're not sure, so that's doubtful. But we know it can cause a syrinx. So a syrinx, as you can see there, the spinal right there. So there's a cyst in the spinal cord. It's not a tumor, it's not anything like that. A cyst in the spinal cord just gets a fancy name, it's called a syrinx. So some people are born with a syrinx and will just watch it. But if your syrinx keeps getting bigger and bigger, that's more important, and sometimes that forces us to do the operation. If the syrinx is lower down, it's the tethered cord component. Okay, so this is a syrinx near the neck. Okay, great. So what's the treatment? So I'll try not to give too many gory pictures for the audience, but first of all, the treatment for Chiari II is, remember Dr. Walker's saying, it's always the shunt. So we will check the shunt first. If they don't have a shunt, then we'll treat the hydrocephalus. And so that's really the key. You'll see us go to that, and almost everyone gets better with that, and it turns out to be right. I don't know how much you guys want to know, but all we do in the back, we remove a little bit of the back of the skull and the back of the first 2 or 3 or 4 vertebrae, and then basically put a little patch, and all we're doing is just giving the brainstem and the spinal cord a little bit more room. When to treat. So this is my emphasis, is rare. Okay? We shouldn't be treating very many Chiari IIs. Hydrocephalus much more common than that, but never preventative. So in the 60s and 70s, you heard a little bit of the history. My forefathers started treating this more often, and in many cases, when they operate, they have an 80% mortality. That means the babies die 80% of the time. If operations are supposed to help, I'm not sure that's a very good operation. If anyone dies 80% of the time, it's a horrible operation. And the reason is because babies don't have 6 liters of blood like I do. They quite often have like 3 pints of blood. And if you touch that bleeding, that torcula, anesthesia cannot keep up and they die of blood loss. So when you hear us being hesitant, we're not trying to make our golf game or anything. This is a major serious issue. So again, you can see I'm hitting the theme. We always rule out the shunt first. If we really do think it's the Chiari II, the shunt's working. They're getting more stridorous and worse. ENT says their vocal cord paralysis is getting worse. We get a sleep study and try to prove it, because sometimes it can just be a simple tonsillectomy and adenoidectomy, and these kids get better. And that's certainly a better operation than a brainstem operation. With the use of microscope and with a slight change in technique going a little bit lower, the mortality no longer is 80%. It's somewhere around 10%, which is still a huge mortality. Like a 10% mortality for an operation these days is huge. Okay, 80% is ridiculous. Necessity. So the other reason why we're hesitant sometimes is sometimes we end up doing it, and the odd time the baby picks up immediately, but that's relatively rare. It's usually some sort of immaturity of the brainstem. The kids slowly get better. We're never quite sure whether to take credit or not. But I think sometimes parents believe the tracheostomy is going to come out, the feeding tube, everything's going to get better, and that's usually not the case. I mean, sometimes slowly. So I think our best, so you're seeing we don't have a great treatment, and probably we don't need to treat very often, but our best treatment is prevention. And so, and the fetal closure. So here's the results. I'm going to talk a lot about the MOMS trial. It came out 3 years ago. And one of the interesting side effects of the study, this wasn't the main part of the study, but they kept an eye on this. So this is a fetus inside a mom's uterus getting an MRI. And you can see that there's a Chiari II. It's not a terrible one, but that fetus underwent closure intrauterine. So mom had a hysterotomy. They took the baby out. I'll show you a picture, and then closed the back. And by closing the back, the pull is not there anymore. The leak is not there anymore. And lo and behold, a lot of the times the Chiari II goes away, or it gets significantly better. So these are the actual results from the MOMS trial. Highlighted. Okay, so you can see postnatal surgery is what most kids get. Like after they're born, it's closed. 96% of them have a Chiari II. Okay, if you do a fetal surgery, only 64. So still the majority, but a much better number. And then just highlighting here is that, and even when they get it, that it's less severe. You can see only 6% get severe anatomical Chiari II versus 22% of the children born on time and then close after birth. So probably with more and more children having the prenatal closure, we're going to see a drop in Chiari II. Okay, hydrocephalus. So this is a much bigger topic because it's much more problematic, as I'm sure everyone in the audience has been touched by this. So just a real quick review of what hydrocephalus is. So the brain is bathed in spinal fluid, and I'll use the term CSF, cerebrospinal fluid. And there's many reasons for this. It's a buffer for trauma. It removes some waste products. It has various causes, and we don't know 98% of them. So, but it relies on a very intricate system of getting the CSF moving around both in the brain through canals called ventricles and around the brain, down the spinal cord, back up, and then it gets absorbed over the surface of the brain. So when there's a block for anything, the most common block, again at the middle age point, is here in the aqueduct. It's the smallest part of the system, so it's just plumbing. Wherever your thinnest pipe is, that clog of hair and plumbing, or here scar tissue closes that over. It's the easiest thing to block. And then, or sometimes the filter on the surface of the brain, we call it communicating hydrocephalus, so the CSF gets absorbed back into the bloodstream to the heart, and it just can't get back to the bloodstream, and that's another cause called communicating hydrocephalus. So once there's a backlog of fluid, the ventricles dilate, and then pressure starts to develop, and that's hydrocephalus. So hydrocephalus is volume and pressure. Pressure is key. So when humans have pressure in our brain, we're symptomatic. We do not like that. So babies can't talk to us and tell us what they're feeling, and probably they're not feeling much. Because their heads are born to take this. So their heads are designed by nature to squish through the birth canal, pop back open. And that's convenient for hydrocephalus because that's what prevents them, because babies rarely get sick from hydrocephalus, like show up in a coma, unlike adults or older kids. So their heads can accommodate. So usually they present with a full fontanelle. You can see the fontanelle with the soft spot. Splayed sutures, those are the growth plates of the head, and they start spreading apart. And when both those things happen, the head gets bigger and bigger and bigger. Towards the end, babies can sometimes vomit, but rarely. There's a million reasons for a baby to vomit. And then poor feeding, again, a million reasons for a baby. So, but those first three things are very specific. Okay? Older kids can talk to us, and so it's like nature gave us the fontanelle for babies that can't talk, which is quite nice. But older kids can talk, and then the fontanelle goes away. And so they can talk to us about headaches, blurry vision. Teachers talk to us about that vomiting or getting drowsy. And then nowadays we're pushing this to the limits more before we treat, especially in babies, and I'll explain why. So how do we make the diagnosis radiologically? This slide is mostly for the last thing, but babies, we try to use ultrasounds as much as possible. The workhorse has always been the CT scan, so that's right here, the CT scan. It's fast, 10 seconds, it's available 24/7. They get them a lot. The problem is that studies are coming out that multiple CT scans can increase your chance of cancers later on in life. Now it's a real small increase, but anything we can do to avoid cancer is. So we've gone away from that. And so the babies are almost all getting ultrasounds, and then we're trying to move to do mostly MRIs now. At this hospital, that's Monday through Friday from 9 to 5. If we're checking your shunt now, you get a fast MRI. So it's like a CT scan, it only takes 49 seconds in the magnet. So the problem is those 6-month-olds to 6 years, they don't cooperate very well. The MRI is a scary place, it's really dark. So we have to give them a whiff of sedation even for 49 seconds. But you're going to see more and more if you come in during work time hours. So we're just ramping up the hospital right now to do these on weekends and nights as well. But that'll take a year probably because it's a lot of change for the hospital. And also we're looking at for changes. So in the bottom there you see an MRI. The normal ventricles go up to that. So that's pretty exaggerated example, but it's a real one. So treatment are shunts. So check my time, make sure I don't go over. So treatments are shunts. So what is a shunt? It's just a silastic tube that goes into the ventricle, into those canals, up to the surface. There's a valve, and then the tube that goes usually into the belly. The valve is to prevent, in case you get appendicitis, that the fluid doesn't start pumping into your head while you're sleeping. So, and to control the flow. There's a picture of a valve. We've been using shunts for now 50 years. It was just, I think, the 50th year anniversary of the shunt. It's effective, it works. Usually go home the next day, it's kind of fast. But there's complications, as this crowd I'm sure knows. They fracture, they infect, about 4 to 10% of the time. And they block, which is the most common reason for fixing them. So in 2009, this was the state of shunt surgery for all shunts, not just for spina bifida, but this is a big part of this group. That 60% of shunts have to be fixed in 2 years. So I mean, nobody would buy a car if, you know, they said, well, there's 60% chance you're not driving this thing in 2 years. Like, so that's terrible. I mean, I won't speak for the manufacturers, but we do drive rovers around Mars. But anyway, so can we do better than this? This is 2009, and I have some evidence that we finally are starting to do better. But for 20 years, we didn't do much better than this. And these are big, big studies. So, what percentage? So, historically, 90% of children with spina bifida, and specifically myelomeningocele, were gotten shunted. And then, just to reverse, when we talk about hydrocephalus, 16% of all hydrocephalus in North America is from myelomeningocele spina bifida. So it's a big chunk, even though hydrocephalus is a bigger pool, but it's still a big chunk. So I'll talk more about the HCRN, the Hydrocephalus Research Network, and spina bifida is a huge part of that network. But this also demonstrates, so this is a study which I did, but looking at all the different types of hydrocephalus and how long your shunts last. So you want to be here. If your shunt always lasts, this is shunt survival. But unfortunately, this green line is spina bifida. So preemie babies and spina bifida babies, shunts block the most, unfortunately. So this is an important problem for moms, dads, and the children especially, but it's also an important problem for the government and for the insurance company. This is children with shunts account for $2 billion a year in the United States. This is a study which Dr. Simon and I did. And so, as we heard, the incidence, so there's a key epidemiological word, incidence is new cases. Incidence of spina bifida is going down slowly, a little bit. It went down a lot with folate, and it's sort of trickling down now. But the prevalence, how many people are alive with spina bifida, is going up because, as you've heard, they're living longer, and that's great. It's a success story, but that's more. This is what the government's scared of. It's more and more costs because these are people with disability coming to the emerge more often. And you can see in this study that children with hydrocephalus, of which spina bifida is in here, sure they come for shunt placement, and these are in billions of dollars. This is a big study. So for shunt fixing, shunt infections, but the most common is just to come in for other reasons, for medical reasons, and it's actually the medical morbidity that's driving most of the costs. Okay, so I talked about the HCRN. A lot of the research I'm going to present today is done by the group of which I'm a part of. And so this is a 9-center group, 2 Canadian centers, Vancouver and Toronto, sick kids. And then us here in Salt Lake, Seattle, Alabama, Texas Children, St. Louis, Pittsburgh, and I think I get everybody. And there's 2 stars in Salt Lake because the data center is here just down the street. So we are trying to end the problem of hydrocephalus, which is, again, huge for this, especially this crowd. So the first thing is why other centers, the NIH, it's always just single centers doing a study of 30 patients, and we're getting nowhere. So I'd like people to come together, make big studies, and start tackling some big problems. So that's what we're doing. So the largest study looking at shunt infections was 200 patients. So we now have 1,000 patients in this study that is waiting to be printed from one of the journals. And we looked at what are the risk factors for shunt infection. Not surprising, it's the amount of revisions you have. The more times we have to operate, the higher risk the patient's at. And also, if the patient has a G-tube or a gastrostomy or a feeding tube, they're at higher risk. Not that shocking, because that's a dirtier site. You know, there's food always there, and there's sometimes a spillage and contaminates the shunt. The problem with the study is great. We figured out what the risk factors of shunt infection are, but they're not really risk factors we can fix. We're not going to not put feeding tubes in these kids, and we're only revising them if they need it. So it directed us, okay, we got to tackle revision. So this is a study we just finished analyzing, so you're seeing this before some of the rest of the world. So the same group of patients, 1,036, and we looked at what are the risk factors of shunts blocking. So if you're young, shunt goes in when you're less than 6 months of age, you're at higher risk. If you have a cardiac problem as well, DSD, a hole in your heart or something like that, you have a higher risk. And if technically we use the endoscope, we use a little camera to put it in, then you're at higher risk for your shunt blocking. Okay? So there's one thing we can't really fix the age, we can't really fix the cardiac, but we can stop using that scope. And once I presented this at the national meeting, scopes are now going away for new shunt insertions. There's myelomeningocele there. So myelomeningocele does not, even though I showed that graph, there was a trend, but it's not significant, which means these other factors are stronger and more important. So it's not really why you have the shunt. One really interesting thing, which makes me extremely unpopular with the companies, is that it doesn't matter what valve you have, they all seem to perform equally. So programmable shunts are 10 to 15 times more expensive, and they don't have any benefit. So if in an uncomplicated baby, generally you shouldn't put a programmable shunt, a $15,000 shunt in a patient, when a $1,000 shunt works just as well, and in some cases better. Okay, so those were the implications of that study, and then I real life implications. Now there's certain circumstances where we do need a programmable valve, but that's just all comers first time you get a shunt. So I said that number, about 60% not buying that car. So how we decided that was sort of 1990s data, we thought we'd relook at it and see if we're doing any better. And fortunately, there's some hope. We are doing better. Still, it's not great, but we're doing better. So only 40% of shunts require fixing at 2 years, which is a major difference, which is saving, you know, tens of thousands of American children operations every year. Okay, so avoiding the shunt altogether. Okay, and so once you have a shunt in, we're making improvements. And so, but is there any way we can avoid the shunt altogether? And so, number one is the fetal closure, the mom's trial. I'm sorry, I don't know if you guys were interested, but here's a baby with Spina Bifida. So here's the MRI, it's got a Chiari II, and there's the Spina Bifida, the open spinal cord, and the CSF sac. There's the operation. That's mom's uterus. That's the baby's back. You don't see the baby, you just see their back, and that's the myelomeningocele that they're about to close. So I'll put that off to make people squeeze. But all right. So when they looked at the study, this was the main part of mom's trial, is to see whether we could lessen the burden of shunts in these kids by doing the operation. And so again, sure. So the primary outcome, well, why don't we just look at this one? So the shunt. So if you got closed after birth, the shunting rate was 82%. And when that was reviewed by experts, 98% they had shunted, 82 were. So there's that historical number, 80 to 90% again. But the kids that got closed, only 40% needed a shunt. So that's the reason why the mom's trial was stopped early. It was supposed to go on for another 18 months, and when they analyzed, that's enough of a difference. They had to stop the trial. Number one, it cost $26 million, but number two is they had the results. There's a difference. So Very interesting. Not everyone's a candidate. Very strict criteria for a candidate, but this is now spread. This is now spreading. It used to be just 3 centers, San Francisco, Vanderbilt, and CHOP in Philadelphia. But now there's 5 more centers across the U.S. And actually we are starting, we've recruited Dr. Bolo, who started up the Texas Children's, and we stole him from Texas Children's. And he is starting up the Fetal program here. We're probably going to close so these kids are now getting teed up here with Paula and Rob, myself. They see a lot of it in maternal fetal medicine, and they get teed up, and if they're candidates, we sort of tie them up in a nice bowl. They're already worked up, and they go to generally San Francisco, to the closest. But if you have family at CHOP or whatever. But soon we're going to close that pipeline, or families are welcome to go, and do them here, because we have one of the highest spina bifida rates in North America. And so this is where these kids live, and we felt, we just felt strong that they should have care near home, and we have the expertise. We're a world-famous center for hydrocephalus and spina bifida. Why don't we do this here? So that's why we stole Dr. Bolo, and you guys will meet him in spina bifida. Okay, so avoiding the shunt altogether. So there's another new 2009, if I had to give this talk, it's a pretty dreary talk. Like, we're going to just talk about shunt revisions and what it looks like and what it infects. Like, nothing had changed for 15 years in spina bifida, and I mean, neurosurgically. Orthopedics has done some great things, how they fix the spine and fix, I'm just talking about neurosurgically, it was pretty dismal. But now we have MOMS trial, and now we have this. And so, this is endoscopic third-ventriculoscopy and cardiac plexus coagulation. Let me explain. I'll explain what this is. So just in case you haven't lost your breakfast yet, I'll show you a video. So I'm just going to show you a video. So what an endoscopic third-ventriculoscopy is, we've been using that. So instead of a shunt, we could put a hole at the bottom of the brain and then get the flow to go through the bottom of the brain. Works great for certain types of hydrocephalus, especially in teenagers and adults. It's a gimme. Like, it works 90% of the time, but it was always a miserable failure in babies. And 90% of hydrocephalus is from babies. So it's really rare to get hydrocephalus as an adult. If you're an adult and you have hydrocephalus, you had it probably since you've been a baby. So the burden is on the babies, and this procedure has been a failure. 20% success rates. So we typically we stopped offering it a few years back because it didn't work. However, a new second part of the surgery came on, and I'll explain what happened. But here's the video, just so you know. So this is the floor of the ventricle. Okay. And then we just poke a hole. So we're in the brain with a small camera that's 3.5 millimeters, and we're poking a hole. I won't show the whole video, but making a bypass. There's very little neurons. Quite a bit. There's like multiple webs, so you can see us with our camera going in there and breaking the webs. And then do you see that? That's the moment that the surgeon. You see this flapping there? That's the flapping. That means we've made the hole, and it's starting. Fluid is now escaping the ventricles and going around the brain where it should have gone to start with. And now the baby can start circulating normally, or relatively normally, without the use of plastic. Okay? So you're seeing the floor beat with every heart rate and with every breath, and that's flow. That's the sign of success. Now that's what we used to do, but it didn't work. But that's the cardiac plexus. So that's the stuff that makes 80% of your CSF. And then we go around, and it's called cauterization. It's a fancy medical burning. And then we go around and burn that on both sides of the brain. Okay. It takes about 2.5 hours instead of a shunt, which takes about 45 minutes. Okay. Is it a game changer? So where did this come up with the idea? So of all places, we like to think, North America, Europe, we invent things, and then it scuttles through Asia and Africa. But in this case, it's reverse engineering. So this started in Uganda, Africa, and because they don't have shunts, and these babies all died. And so he had no other choice to push this, because you do this, and it's much better for people that won't come back and see you, okay? And so Dr. Ward, who moved his family to Africa, and for 7 years started doing this, and he's now moved back, and he's at Harvard. And so this is the success. So this is in African children. So without the choreoplexus, 47% chance of success. But you got to remember, he had to make those work. So he was much more aggressive than we would ever have been here, because shunts, you know, they're a pain, but children do very well and go to college with shunts and everything. So, but when he added this choreoplexus, that second part, the all-comers, he got 66%. And that was early on with the first two, I think, how many kids were in this study? 550. Okay, now they're up to 7,000. Now Africa is up to 75% success. Okay, so this Africa topped the world, and so they've come back, and when we said, yeah, I don't know if that'll work in this population. It's different. We're more modern. Shunts are better here. They're more available. Insurance companies pay for them. But we're starting to do it more. And I'll show you about the impact. I have some slides on that, about specifically what's happening here. So are we making a difference in hydrocephalus? So this is just primary children's stuff. And so here's some more hope. I'm trying to end on a high note, because there it is. So this is what we're seeing, is that these are shunts. So shunts are staying, new shunts are staying about the same since 2008. But that's when the network started. And so you can see a slight decline, but that's the ETV-CPC. So less shunts going in because of that. But it's about a flat number. But you see shunt revisions going down like that. That's what we're looking for. Once you put a shunt in, it stays in, and it doesn't need to be fixed. You don't need to come to the ER. So this is the graph we've been waiting for since the 70s. Okay, so that's just primary children. Our infection rate is creeping down. It's not as low as, you know, it used to be as high as 9%, but now it's 7-point-something%. So it's creeping down, and it's creeping down across the network. So the network being representative of Canada and the US. And here we just broke our record. So we have probably the most shunted population that we look after here in primary children's in the world. I think, well, sorry, not Africa. In Uganda is the most, but we're probably second. So we see a lot of shunts every week. And we just broke our record of 99 days without a shunt infection. We have a sign in the operating room like Toyota, you know, 50 days since Charlie caught his arm in the machinery. We have like, how many days since our last shunt infection? So to try to help decrease shunt infection. Okay, so ETV-CPC, I just want to show its impact that it started to have here. So this is within the network, so the 9 centers, and you can see that this is when he published that paper. Surgeons are a very conservative group, so it takes us a while. We don't quite believe it, and then we can see we're starting to drink the Kool-Aid, and then we chugged her down. Okay, so in 2012, more and more studies came out, and so I've started doing them here, and I think we've done 40 now, which doesn't sound like much, but it's one of probably in the top 3 around the country of having done them, with Ben Warp having done 3,000, and then some of us doing 40 to 50, and doing more and more each week. So since May 2012, 31 children have been born with myelomeningocele in our catchment area, Idaho, Wyoming, you know, are in the Intermountain area that we've looked at. So just to give you some perspective, that doesn't sound like a lot of patients. The year I did my fellowship, only 7 children were born in Canada in 2005 with myelomeningocele. So that's the entire nation of Canada. Canada's always 10 times smaller than the US, but still, this is only one area of the country. So that shows how prevalent spina bifida is here. And that's why we're bringing the programs here. So 32% of the kids didn't need a shunt at all. Now, some of that was moms. We had 6 moms kids. So 32% didn't need a shunt. Now, ultimately 32 went right to shunting, and then 11 were considered candidates. Not everyone's a candidate for an ETV-CTC, but 11 were. I abandoned 2, but that's before I went to Uganda, and I just started doing them based on talking about the work and training. But then I actually just went to Uganda in February and did in 3. So we'll do 1 of these a week, maybe. So I did 12 a day. So they're become much more aggressive, and so in the 9 that we were able to do the ETV-CTC, all 9 are working for spina bifida. So the important number is this red number. So since May of 2012, only 40% of children have a shunt with spina bifida now. You got to remember that used to be 80 to 90%. So, and that's coming down. There's a learning curve, and more patients are becoming candidates. We're going to study this very closely over the next. There's going to be probably a randomized control study coming out over the next 6 to 12 months. So, in fact, Ben worked at Harvard. Now, Boston has a much lower rate of spina bifida, the Northeast does. But he's got this down to 14. So we're heading down towards that just because he's more aggressive on who he can do. And we're becoming more aggressive as well. So from 90% of shunts to now 40% of this population of kids are being shunted.
But if you have a child that's been shunted and they end up with a failure, is there a change in what they do for them or what?
No, I mean, we've tried that before. That's been a bit of a failure. So once you've been shunted, the body probably shuts down. How we get rid? I showed that flow of CSF. That's just the main highway. Now there's a lot of side streets. There's lymphatics where some of the CSF escapes into the brain, and the brain actually absorbs it itself. Some of it goes, believe it or not, into the nose. And you know, we've always heard reports from moms that say, he looks a bit swollen, and then he's got a drippy nose every time he shunt a lot. We're like, yeah, you're crazy. And I'm like, yeah, you're probably not crazy. Like, it's probably true. It's really, really subtle, but it's only a mom or a dad can notice. So, by shunting, the body just gets lazy, to be frank. Just like, oh yeah, the belly can handle that no problem. It can handle liters of fluid every day. But we think those secondary pathways have dried up. So you cut the side streets out, and the side streets, even though they're side streets, they're still important. And when we pull these shunts out, some people report about half you can get out. I'm not sure how they're getting that. I think it's a lack of follow-up, to tell the truth, but because I found it a dismal failure. Once you have a shunt and you try to take the shunt out and do the third ventriculostomy, it's like you're lucky to get 15% success. And it's riskier. So these are babies whose ventricles are really, really stretched out. So big ventricles, the camera's in there, we have lots of room, we're not bumping anything, it's floating in the space. Babies are just ideally set up for this. If you can imagine, this is usually what a shunted kid would look like with a shunt. Then it's even hard to even get the camera in there. Even when you're in there, there's just no room to maneuver, so the risks go up. Okay? This is very little risk of bumping things and hitting the wrong thing. Because you got to remember, a camera when you're in there can only look straight ahead. It can't look behind you or beside you, and so you have to really know your anatomy perfectly. That's a good question. That comes up all the time in our meetings.